Virus. What do you mean by picorna? Do you have any idea why its name was picoRNA or picorna virus? That means small RNA virus. PicoRNA name has come from it is a small RNA virus. They are usually small, 20 to 30 nanometer. They have icosahedral symmetry and unenveloped. So they don't have any envelope. Now can you explain what is the most important picorna virus you must know? Polio is the most important. Another picorna virus you have already read, that is hepatitis A, is also included in the picorna virus. So they are divided into three genera. One is enterovirus, one is rhinovirus. Genus hepatovirus includes hepatitis A. Enterovirus, 5 groups. Poliovirus, you all know poliovirus have 3 serotypes, 1, 2, 3. Coxsackie A virus, 23 serotypes. Coxsackie B has 6 serotypes. And ecovirus, 31 serotypes. And unclassified enterovirus has 30 serotypes. What are the general characters? They are mostly transmitted by fecal-oral route. They fecal-oral route, they need to be acid stable if they want to reach the intestinal epithelium. Main multiplication of the picorna virus or poliovirus either in the pharynx and or intestine. So they must be acid stable. They replicate in the pharynx and small intestine. They cause neurological and non-neurological disease, and they are shed in the stool. Transmission, already I have mentioned, fecal-oral route, drinking water contaminated with infectious fecal material, eating uncooked foods, contamination of fruits and salads. So where enterovirus will be more endemic, where the hygiene is not proper, sanitation is not proper, absence of proper drinking water, low education level and crowded living conditions. Poliomyelitis. Now let's start the most common poliovirus. What is the common serotype which causes polio? Two things. Polio, why we should know? It is near to eradication. Polio will be eradicated in near future. Already poliovirus 2 and 3 already eradicated, and India. So 1, 2, 3, 1 is more paralitogenic. এখন most cases are due to 1. They are enteroviruses transmitted by fecal-oral route, the same. Now can you tell which countries still having polio cases, active polio cases or polio disease? Only 2 countries have. One is, it was named Pan, there is no more case from there. So 2 countries where polio cases are still happening. One is P for Pakistan and A is Afghanistan. In all other cases, India, most polio cases we are getting are vaccine associated polio. That is not due to wild polio virus. So mostly they are from Indian cases are vaccine associated polio. That you must know, because so their structure, what is the morphology? They are enterovirus, family Picornaviridae, genus is enterovirus, very small, 28 to 30 nanometer in size. They are non-enveloped, spherical in shape and have icosahedral symmetry. Capsid consisting of VP1 and VP4. You must remember this is VP1. Serotype 1, 2, 3 differs in VP1 region. So they differ in VP1 region only. So they are spherical in shape. Capsid composed of 60 subunits, and they have single stranded positive sense RNA virus. What is positive sense RNA virus? What is positive sense RNA virus and what do you mean by negative sense? Positive sense RNA virus means this RNA can act as messenger RNA and can form the protein or peptide particle. So this positive sense RNA, this RNA acts itself as messenger RNA and they can produce their own protein. That is positive sense. Negative sense RNA virus cannot produce their own protein. Single stranded positive sense RNA virus VP1 to VP4. So classified according to wild poliovirus and vaccine associated poliovirus. These are the two types of poliovirus. What is vaccine associated? They regain the neurovirulence and capable of producing disease. Poliovirus 1, poliovirus 2, wild poliovirus 3. All the three strains are identical, mainly they produce similar clinical features. If infected, the patient will have similar clinical feature. Only difference there is genetically but immunologically distinct in VP1 region. So that means if without vaccine, one person is infected with the wild poliovirus 1, will he be protected from 2 or 3? যদি 1 এ কেউ ইনফেক্টেড হয় সে কি আদার সেরোটাইপের ক্ষেত্রে প্রোটেক্টিভ? No, all the 3 serotypes are different genetically. That's why all 3 antibody must be there. So one type of poliovirus infection cannot protect from other 2. That's why when we give vaccine, initially all the 3 serotypes were included. So the antibody response is type specific and not cross-protective. And each strain needs to be eradicated individually. Currently, all the natural cases are due to wild poliovirus 1. And wild poliovirus 2 and 3 are globally eradicated in 1999 and 2019. This is the 2 antigen. One is called D antigen and one is called C antigen. Importance of D antigen. The anti-D antibodies are protective. Anti-D antibodies are protective. Therefore, the potency of the injectable polio vaccine can be measured in terms of D antigen unit. And C is capsid antigen. Now, how the pathogenicity occurs? What are the method of spread? What is the common pathogenic feature? That is neurological features. So how it reaches how it spreads from intestine to the anterior horn cell, how it spreads. There are 2 methods of spread. Either it can be spread by subepithelial tissue, which is the local lymph nodes. So there causes the primary viremia. And after multiplication in the lymph node, they produce secondary viremia. And the virus reaches the CNS. So, first way of spread from intestine is through blood. So, 2 types of spread. One is blood spread and second, direct neural spread. How it spreads, direct neural spread? Give example where direct neural spread occurs. One is after tonsillectomy and after any IM injection this spread can occur. So direct neural spread are 2 ways. One is after tonsillectomy. So either it spreads to CNS by blood or by direct. Now what is the pathogenic feature? They usually involve the anterior horn cells of the spinal cord and distinctive plaques produced in the grey matter. They multiply in the intestinal epithelial cell Then submucosal lymphoid tissue. What is the receptor? Receptor CD155. It can be an MCQ. What is the receptor of human receptor for poliovirus? That is CD155. Hematogenous spread, most common. Viral spreads to regional lymph nodes and spillover, and neural spread. Virals may also spread directly through nerves. The final target site for poliovirus is anterior horn cell. Neuron degeneration, virus infected neurons undergo degeneration. Earliest change, another MCQ, earliest change is Nissl body, NISSL, Nissl body is the earliest pathologic change in the anterior horn cell. Another point, the pathogenic clinical feature, remember the clinical feature is not proportionate to the pathologic changes. So pathologic changes is more in comparison to the clinical features are less. Nissl bodies are aggregated ribosomes. Incubation period 7 to 14 days. What are the stages of infection? One is inapparent infection. That means patient does not have any clinical features of polio infection. That is inapparent infection. And 91 to 96%. Most cases are inapparent. So 91 to 96% patients don't have any symptoms after infection with poliovirus. Then abortive infection. About 5% of the patients develop minor symptoms. That is called abortive infection. And fever, malaise, sore throat, and non-paralytic polio. How the patient presents in non-paralytic polio? It presents with aseptic meningitis. 1% is non-paralytic, aseptic, and paralytic poliomyelitis is less than 1%. Now, what type of paralysis occurs in polio? What type of paralysis? Remember this term, descending asymmetrical acute flaccid paralysis. So, you must remember this term, the clinical feature is descending asymmetric acute flaccid paralysis. That means if hip and knee, if you see, the hip will be involved prior to knee. Mainly the proximal muscles are involved first, followed by the distal muscles. Is there any sensory loss in polio? These are motor loss. Descending asymmetric flaccid paralysis. Is there any sensory loss in polio? Polio does not have any sensory loss. So, no sensory loss in polio. Only the motor involvement, no sensory loss. So, these two parts must be remembered in the clinical feature, descending asymmetric flaccid paralysis and no sensory loss. There is a picture of polio, asymmetric, the hip is involved first, knee is not involved, the same picture. Descending asymmetric, proximal muscles are affected earlier, proceeds towards the extremity, which lead to tripod sign. Another MCQ question, tripod sign is seen in polio. Why tripod sign? Because hip is involved prior to knee. So, when hip is involved prior to knee, there will be flexion at the hip. So, flex your hip and both arms are extended towards the back. Other sides, spinal, bulbospinal, bulbar. Which is most dangerous? Spinal, bulbospinal, bulbar. If there is bulbar involvement, what will be the clinical features? Bulbar paralysis or bulbar involvement, what would be the clinical features in bulbar? Bulbar means pons and medulla are affected. So, what will it affect? What will be the clinical feature in bulbar polio? Nature of paralysis varies. Respiratory insufficiency or dysphagia are common in bulbar paralysis. So, there will be respiratory insufficiency in bulbar polio. Usually, it A biphasic course. The disease progress typically biphasic, first aseptic meningitis, then recovery, then return of fever with paralytic features, 1 to 2 days later. So biphasic course. Cranial nerves are also involved. No sensory loss, already I have mentioned. Paralytic diseases are more common in older children, in pregnant women, and following heavy muscular exercise. Tonsillectomy predisposed to bulbar poliomyelitis. Which nerve is involved in tonsillectomy? Direct neural spread. Which nerve, which cranial nerve is there in the tonsillar fossa? Tonsillar fossa, which cranial nerve is there? Glossopharyngeal nerve. Glossopharyngeal nerve is there in the tonsillar fossa. Now laboratory diagnosis. Virus isolation is done in primary kidney cell line, throat swab, rectal swab or stool samples, and viral growth is detected by CPE or viral antigen. What is CPE? So virus culture, what is to be done? Virus culture in primary kidney cell line, throat swab, rectal swab, stool sample. Now still in India, there is a surveillance for acute flaccid paralysis. How you do the surveillance for acute flaccid paralysis in India? What is the protocol? What sample will you send? Acute flaccid paralysis that may be due to polio, may be due to non-polio. But you have to send some sample. What is that sample? That sample is stool, because the virus shedding persists till 8 to 12 weeks. 8 to 12 weeks, up to 8 to 12 weeks, viral shedding is done. Antibody detection by neutralization test. Now another point, neutralization test. We have read in dengue, there are two types of antibody. One is neutralizing, one is non-neutralizing. There is one MCQ, how will you detect the neutralizing antibody in dengue? What is that test called? For detecting the neutralizing antibody. I told that time, plaque reduction neutralization test, PRNT. By this test, it is not routinely done, but in MCQ it can be asked. Plaque reduction neutralization test in dengue is done to detect the neutralizing antibody. Now throat swab, specimen usually is up to 3 weeks of illness. Virus can be recovered from throat swab, up to 12 weeks from stool sample. CSF or blood is very rare. Sewage testing. Sewage testing is another part of surveillance. Screening of sewage for detection of polio is routinely conducted under polio eradication program. Specimens should be kept frozen during transport to the laboratory. Primary monkey kidney cell line, cytopathogenic effect. CP is cytopathogenic effect. So what cytopathogenic effect occurs in polio? That means crenation and degeneration of entire cell sheet. Antigen detection, PCR. What type of PCR will detect the polio virus? If you want to name the PCR, what is it? Any DNA PCR is called DNA PCR. What is PCR for RNA virus, detecting RNA? That is RT, reverse transcriptase. One RT is for real time and one RT for reverse transcriptase. Reverse transcriptase PCR. You have to mention reverse transcriptase PCR for detecting any RNA virus. A rise in antibody, 1 to 2 weeks of interval, neutralization test. First infection, poliovirus produce tie-specific response. The subsequent infection induce antibody against group-specific antigen. Common to all three serotypes. Real-time multiplex reverse transcriptase PCR using primers from VP1 region. Why we are using VP1 region primer? Because the serotype 1, 2, 3 differs in VP1 region. That's why we are using primer from VP1 region. Vaccine poliovirus and vaccine-derived poliovirus can also be detected by PCR. Now vaccine. Vaccine you should know polio because it is part of universal immunization program. Can you tell what is the change in the universal immunization program? Which polio vaccine was initially given? There are two types of vaccine. Oral polio vaccine and injectable polio vaccine. This is live attenuated and this is killed. And there are two names. One is Salk. Remember K for killed. K for killed, Salk, and oral is Savid. So oral poliovirus and injectable poliovirus. Salk has prepared the injectable polio vaccine in 1952. Each dose 0.5 ml contains 80 units of all three poliovirus serotypes. Total 80 units, 40 from type 1, 8 from type 2 and 32 from type 3. What are the advantages of oral polio and injectable polio vaccine? Either full dose intramuscular or fractional dose. This is the new concept. Fractional dose of IPV. Fractional dose of IPV, 1/5 of the full dose, that is 0.1 ml intradermal route at upper arm. Now, what are the advantages of OPV and IPV? This is cheap and this is expensive. So, this is one part, that's why oral pilot. Second, what is the advantage of oral polio vaccine? This is a change in the national immunization schedule. 2015 IPV was introduced. Can you tell, do you have any idea why IPV, we are switching to IPV from OPV? For long we were on OPV. Now we are shifting to IPV. What is the main reason for shifting to IPV? Any idea why we are shifting to IPV? To decrease the last, initially I mentioned, the most cases of polio in India not from oil poliovirus, it is either vaccine associated poliovirus or vaccine derived poliovirus. So both are more common in case of OPV, and there is no case of vaccine derived or vaccine associated poliovirus in IPV. That's why we are shifting to IPV to decrease the vaccine associated polio. That's why we are shifting towards IPV. But in 2017, we have started fractional IPV for intradermal route, scheduled at 6-14 week. What is the schedule of OPV? First is at birth, then 6th week, 10th week and 14th week. OPV was given. Now what we are doing along with OPV at 6th and 14th week, we are giving fractional. Why we are not giving the full dose? Any idea? First is the cost, decreasing the cost. IPV is costlier, and second is the production of IPV was not up to that mark, so that the whole OPV can be changed to IPV. So this is the two reasons why we are giving fractional IPV. This change was made because two fractional IPV given intradermal route at 6 and 14 week has shown to provide higher seroconversion than a single dose, and IM given at 14 weeks, so cost saving. So initially when IPV transition was started, we were giving a single full dose at 14th week. 6th and 10th week we are giving OPV. Then we have converted to two fractional dose of IPV at 6th and 14th week along with bivalent OPV. So OPV is continuing, we are adding fractional IPV. What are the advantages of IPV? Efficacy 80 to 90% is much safer. Even it can be given in immunocompromised people because it is killed vaccine. It is killed, IPV is killed vaccine. Does not cause vaccine associated paralytic polio. more stable, does not require stringent storage. OPV was developed by Albert Sabin. OPV is available trivalent. Now what OPV we are giving? We are giving trivalent or bivalent OPV. Presently what we are giving? This to be remembered because it is asked. Previously it was all the three serotypes were included in the vaccine, but now only bivalent OPV is given. OPV contains initially type 1 3 lakh, type 2 1 lakh and type 3 3 lakhs were given. But now we have converted to bivalent OPV, serotype 1 and 3, and monovalent OPV still not in use in India with 1. So why we are shifting to bivalent OPD in place of trivalent? The cause is same. The type 2 is associated with this type 2 or serotype 2 is associated with vaccine derived poliovirus. So that's why we have converted to trivalent to bivalent OPV to decrease the rate of vaccine derived poliovirus. So earlier trivalent OPV used, now serotype 2 has been eradicated from 1999 and high risk of causing virus-induced paralysis. Trivalent OPV is stopped and replaced by bivalent from 2015. Total 5 doses are given, 0 dose at birth, can be given within first 15 days if you miss the first dose, first, second, third dose at 6, 10 and 14 weeks and another booster at 16 to 24 months. Efficacy is 90 to 100%. Now, what are the advantages of OPV? Have you heard the name of herd immunity? Herd immunity, what is the spelling of herd immunity? OPV advantages, first advantage is herd immunity. Remember the spelling, it is H-E-R-D, not H-A-R-D. Herd immunity is the most important advantage of OPV. So herd immunity. What do you mean by herd immunity? Any idea about herd immunity? Herd means it also gives some immunity along with the subject. It gives immunity to the community also because it spreads by fecal-oral route. So it is OPV strains being alive can shed in the stool and spread in the community by fecal-oral route. So it can induce herd immunity. That means it provides both individual and community protection. So that means herd immunity means immunity to the community also along with that individual. OPV is a vaccine of choice during epidemic. It also produces local immunity. Local immunity means it produces mucosal IgA. Hence provides local immunity. It is cheaper than IPV and easy to administer as given by oral route. Safety. OPV is otherwise safe, but it is risky to give in immunocompromised. OPV is unstable vaccine where you should store the OPV. It should be stored at minus 20 degrees centigrade. So it is a minus 20 refrigerator must be there to store OPV and it is also stabilized by magnesium chloride. The side effect it can cause vaccine associated and vaccine derived poliovirus. Another disadvantage, there are when you are in an immunization camp, you should remember these are the 2 or 3 things why the OPV is less efficacious, becomes less efficacious. One is interference. When you are in immunization camp, you see when the child is having fever, the immunization is not given on that day. Why? Because child may have another viral infection that will interfere with the efficacy of the polio virus. So that's why it is when you go to any immunization camp or immunization center, they know if the child is having fever, vaccination is stopped on that day and usually asked to come after the fever subsides. That means to decrease the interference by other viruses. Diarrhea. If the patient is having diarrhea, OPV is not given because diarrhea will wash out the vaccine. Another thing you should tell the mother that there would be no breastfeeding 30 minutes before and 30 minutes after the vaccination because that breastfeeding can OPV gets washed out in stool if you breastfeed within 30 minutes. Now the last part, vaccine associated poliovirus and vaccine derived poliovirus. What is the difference? Main difference between vaccine associated and vaccine derived. Usually you can expect short note from these, the vaccine associated poliovirus and vaccine derived poliovirus. What is the main difference between vaccine associated? Why there is two names? Genetic difference with all genetic difference with wild poliovirus is less than 1%. Genetic difference. And it is more than 1%. Which is the commonest serotype that is involved in vaccine derived? It is type 2. So, vaccine associated poliovirus, all cases of paralytic poliovirus occur after OPV administration. They are similar to OPV. So, if paralytic polio occurs, the clinical feature will be same as polio. Genetic divergence is less than 1%. It can occur in the OPV recipient as well as in the close contact. So, VAP can spread to close contacts but is not capable of circulating in the community. Can VAP spread to other communities? Can community outbreak occurs after vaccine associated poliovirus? Why community involvement does not happen? In vaccine associated poliovirus, the community involvement usually do not occur. Why? Because in India, most have already taken the poliovirus. As the difference is less than 1%, there is a baseline immunity in the community to prevent vaccine associated poliovirus. So that's why usually community spread does not occur. Largely because of OPV related virus, one case per 2.7 million. Most common serotype is type 3 followed by 2. So, type 3 is the most common, followed by 2 and followed by 1. So, in both the case 2, that's why 2 has been removed from the trivalent OPV. So, most common is type 3. Vaccine derived. Live attenuated vaccine strain undergo genetic changes. So, genetic change would be more than 1% from the wild poliovirus. Capable of producing polio, it is clinically indistinguishable from the infection. Now, this is 3 types of vaccine derived poliovirus have been recognized. MCQ has come previously in the EMS. One is circulating vaccine derived poliovirus. One is immunodeficient vaccine derived poliovirus and third is ambiguous. So these are 3 types of vaccine derived poliovirus have been recognized. This strain can circulate in the community. So they cannot circulate. Community spread does not occur, but community spread occurs in case of vaccine derived poliovirus. Genetic divergence is more than 1%. Same threat to the community as wild poliovirus. Circulating vaccine derived poliovirus are more common. Since 2000, vaccine derived poliovirus outbreaks have occurred in several countries. Majority of circulating cases are due to type 2, followed by type 1. In 2019, 365 cases of circulating vaccine-derived poliovirus cases were reported. 325 were from non-endemic countries. Man is the only reservoir. Most cases are subclinical, so if there is a clinical case, there must be 1,000 subclinical cases. There is no carrier state. Period of communicability. Communicability when the patient can spread the virus. Communicability is 7 to 10 days before the onset of symptom up to 2 to 3 weeks thereafter. Pulse polio immunization was initiated globally from 1995 to 96. 2 rounds of pulse polio 6 weeks apart, given between 18th January and 11th March. AFP surveillance. I have already mentioned about AFP surveillance. How will you do the surveillance for polio? AFP surveillance, any children less than 15 years of age having flaccid paralysis, stool should be sent to the proper center for detection of polio. So for surveillance, stool specimen has to be sent, 2 stool specimens 6 weeks apart. Now what are the other enterovirus? Just know the name. Coxsackie A. What is the infection? What are the infections caused by Coxsackie A? Coxsackie A, upper respiratory infection, sometimes meningitis and encephalitis, and harpangina. Harpangina, why you should know? It is a differential diagnosis to acute tonsillitis. This is one of the differential diagnoses of acute tonsillitis. Hand, foot, mouth disease. Which patient is usually affected by hand, foot, mouth disease? It is caused by Coxsackie A. Short note has come from this hand, foot, mouth disease. Remember, this is caused by Coxsackie A. Hand, foot, mouth and hand, foot and mouth are involved. It usually occurs in school-growing children. Develop on buccal mucosa, hands and vesicles develop. Recovery is usual. Coxsackie B, febrile illness, upper respiratory tract infection, meningitis, encephalitis, myocarditis, pleurodynia. Can you see any idea about pleurodynia? Sometimes there is no symptom, patient complains of pain in the chest during taking respiration. If there is no injury to the rib or any pleuritis, you may take it as a pleurodynia. There is X-ray is absolutely normal. That pleurodynia is caused by Coxsackie B. Ecovirus, febrile illness with rash, upper respiratory infection. So, in polio, you must know the types of vaccine. What is the difference between the OPV and IPV? What are the advantage and disadvantage? And always read about vaccine-associated poliovirus and vaccine-derived poliovirus, because these usually comes as short note, and explain why also. So vaccine is most important part of the polio because it is on the verge of eradication. It is having an outbreak like COVID or any disease which are going to be eradicated in near future. These are the 2 important topics where question usually comes.
Today's topic is the Paget's disease of bone. So coming to the basic physiology, can you tell me like which 2 cells are involved for bone formation and bone resorption? Osteoblasts and osteoclasts. So from where do these cells come? Which one comes from mesenchymal stem cells? Osteoblasts, okay? And from where does osteoclasts come? From hematopoietic stem cells, okay? So hematopoietic stem cells, okay, so as you know, this is for osteoclasts, okay? And osteoblasts. So osteoclasts, they come from hematopoietic stem cells, okay? From hematopoietic stem cells, you get the precursor osteoclast cells, okay? From there forms mononucleated osteoclasts. ঠিক আছে, বুঝতে পারছো তোমরা? Okay. From there comes mononucleated osteoclasts. Now these mononucleated osteoclasts, they will merge to form multinucleated osteoclasts. So osteoclasts are key activity, bone resorption. Okay. Now coming to osteoblasts, these come from mesenchymal stem cells. They form the precursor osteoblasts and then further they form the osteoblasts. Osteoblasts are key function, bone formation, and they are mononucleated cells. Okay, they have one nucleus. Coming to our topic, it is Paget's disease of bone. So, the condition was initially it was described by Dr. James Paget in 1877. So, it is also known as osteitis deformans. Now, what happens? There will be partial or complete involvement of a single or multiple bones by exaggerated rates of resorptive and osteogenic activity leading to bone thickening and deformity. ঠিক আছে? মানে the balance between the osteoblast and the osteoclast is hampered in this case. So Schmoll, one more scientist, he believed that approximately 3% of everyone above 40 years of age had this disease. So coming to the predilection, this disease usually affects the axial skeleton. ঠিক আছে? Axial skeleton মধ্যে কি পড়ছে আমাদের? Skull থাকবে, spine থাকবে, pelvis থাকবে, ঠিক আছে? So the most commonly affected bones are pelvis, followed by the tibia, the femur, the skull, spine and clavicle. But any bone can be affected in this case. Okay? And it is rarely seen in the hands, feet, ribs and fibula. So now this disease is most common in the Europe and North American regions, and it is rare in Asia and Africa. So the etiology, coming to the etiology, the cause is unknown, but occasionally hereditary influence is noted on chromosomal 18q. So there might be a genetic mutation that can cause this disease. Also, it is found that viral infections like paramyxovirus can cause this disease. Then endocrine and metabolic disturbances are unlikely because despite extensive involvement, many bones are free from this disease. So coming to the pathophysiology, this is mainly a disease of the osteoclast. ঠিক আছে? So this disease has three phases. It has a lytic phase, a mixed lytic and a blastic phase, and a sclerotic phase. So different skeletal lesions may progress at different rates. At a given point of time, multiple stages of this disease may be demonstrated in different skeletal regions of the same patient. ঠিক আছে? Multiple bones affect হতে পারে, single bone affect হতে পারে, ঠিক আছে? So now what are the clinical features? So initial presentation of the patient will be what? He or she will come with a pathological fracture. So what is a pathological fracture? মানে because of a trivial trauma fracture হয়ে যাচ্ছে, ঠিক আছে? Just by a trivial trauma, মানে তোমার আর আমার এটা হবে না এই ফ্র্যাকচারটা যদি হয়, ঠিক আছে? যেমন এরকম হয় যে অনেকে বলে যে আমি বল করতে গিয়ে হাতটা ফ্র্যাকচার হয়ে গেল। সো এটা আমি আর তুমি যদি বোলিং করি তাহলে কি ফ্র্যাকচার হবে আমাদের? So that is called a pathological fracture, means there is some pathology in the bone because of which the bone is weak, and because of the trivial trauma the bone is getting fractured. Okay, so the initial presentation will be the patient will come with a pathological fracture. So mainly the patients are asymptomatic unless and until he or she is coming with a pathological fracture. Then they may have bone pain and deformities. Then bone overgrowth or deformity may cause osteoarthritis and nerve impingement, যার জন্য further pain complaint করবে patient. Now the diagnosis is mainly radiologic unless and until যদি incidentally কোনো blood tests করলো and the blood is coming positive for few markers which I'll come in the further slides, and biopsy is done if indicated. সব কেসে we don't do a biopsy. So coming to the lytic phase. So lytic phase এ কি হবে? Which cell is helping in the bone resorption? Osteoclast. So you will see more of osteoclastic activity in the lytic phase. So the bone is resorbed by osteoclasts, which are numerous, and they will have more than 100 nuclei. Okay, and the bone turnover rate is increased as much as 20 times than normal. ठीक है? So coming to this picture, okay, this is a mixed lytic and blastic phase. এখানে কি হচ্ছে? The osteoclasts are eating the bone and the osteoblasts তখনই they are starting to form new bone. Okay, so this is a mixed phase where you can see both lytic and the blastic cells. So as you can see here, these are the osteoclasts. Okay, see, you are seeing multinucleated giant cells, and these mononucleated cells which are surrounding the bone is the osteoblasts. ठीक है? The single dark nucleated cells are osteoblasts. So this is a mixed phase. So there will be rapid increase in bone formation from numerous osteoblasts. The osteoblasts will look normal, okay, and the newly formed bone is abnormal with collagen fibers deposited in haphazard fashion. As osteoclastic and osteoblastic activity repeats, high degree of bone turnover occurs. So coming to this picture, as you can see here, there is an osteoclast which is eating the bone. Okay, can you see that? This is a multinucleated osteoclast, and these single cells which you are seeing, they are the osteoblasts. Okay, so this is the haphazard bone which is forming. You can see these are the cementum lines which are seen on the bone. Now coming to the sclerotic phase. In the sclerotic phase, what happens? The bone formation dominates and has a disorganized woven bone pattern and is weaker than the normal bone. So the woven pattern allows the marrow to infiltrate by excessive fibrous connective tissue and blood vessels, leading to a hypervascular state, and eventually osteoblastic activity also declines and enters a sclerotic or burnt out phase. So যেখানে there will be more sclerosis, there will be fibrosis of the bone. Okay, so fibrosis of the marrow হলে কোন stain we can see the fibrosis? Collagen fibers ইয়ে করার জন্য আমরা কোন stain দিই? Special stain bone marrow তে যেটা ইউজ করি, very commonly used stain, reticulin stain. Okay, so if we do a reticulin stain, it will be positive in this sclerotic phase. Okay, so continued bone resorption is minimal or absent. এখানে osteoclastic activity আমি অত দেখতে পারবো না, ঠিক আছে? So as you can see here, again there is an image. See, these are the irregular cementum lines which you are seeing, which is also known as the jigsaw puzzle pattern or the mosaic pattern. ঠিক আছে? এই দেখো, এখানে you can see it more clearly. See, these are the cementum lines which are haphazardly arranged. Okay, because of increased bone formation, this is looking like a mosaic pattern. Okay, so this is what we see in a bone biopsy. So this is a কোন phase হবে এটা? It is the sclerotic phase, right? Okay, so now coming to the complications of this disease. Now ki hobe? There will be fractures and bony deformities, then secondary osteoarthritis, then neurological complications like nerve root compression and cauda equina syndrome. Then jodi skull involvement hoy, patient will have deafness, vertigo, tinnitus, dental malocclusion, basilar invagination and cranial nerve disorders. Now coming to sarcomatous degeneration, very rarely a Paget's disease can transform into a sarcoma. Okay, it is very rare, and there will be increased bone vascularity, because of which patient will have high output cardiac failure. So coming to the surgical complications, because of this high vascular marrow, when patient undergoes surgery, there will be profuse bleeding. ঠিক আছে? And the structurally the bone will be very weak, and spinal and epidural anesthesia can be difficult in these cases. Now coming to the investigations. Okay, so investigations, usually we do a serum alkaline phosphatase level. Okay, if it is increased, then we can suspect a Paget's disease. Okay, so serum alkaline phosphatase or bone specific alkaline phosphatase is done for these patients. In these patients, the serum calcium and phosphate levels will be normal, okay? And urinary markers are there, which are hydroxyproline, deoxypyridinoline, and C-telopeptide and N-telopeptide. These are seen in urine, okay? But usually we do a serum alkaline phosphatase and a bone specific alkaline phosphatase level. Normal alkaline phosphatase level ki hoga? Okay, I'll come to that later. Now coming to the X-ray findings. So primarily I told you all that Paget's disease is diagnosed by radiological findings, okay? Firstly, we don't do a biopsy. So coming to the radiology. So here what you are seeing, which two bones are you seeing over here? Tibia and fibula. So as you can see, this is the tibia, okay? So you can see that the posterior cortex of the tibia is thickened. And these hypodense spaces which you are seeing, thik ache? These are the loser's zone, okay? And you can see that since the posterior cortex is thickened, the medulla has narrowed, and because of which the tibia is showing a bowing. So there will be bowing deformity, okay? Now coming to the pelvis. In the pelvis, what do you see? What is this line called? It's the iliopectinate line. So it is prominent, okay, it is thickened, and so this is known as the brim sign. Since this is the pelvic brim, you are seeing a prominent iliopectinate line. This is not seen in normal patients, okay? Normal persons, you won't see this. Then coming to the skull, what you are seeing? You are seeing osteitis circumscripta or the cotton wool appearance, okay? So here you can see here this area has become hypodense, okay? Then coming to the Tam O'Shanter sign. Here what do we see? We are seeing that there is a increased diploic space in the skull, and the cranial cavity is also increased. See how the cranium has increased in size? It is looking as if the person is wearing a hat. Okay, so that's why it is called Tam O'Shanter sign. Which one is the diploic space over here? Skull diploic space. What is the skull's diploic space? The space between the inner and outer tables, correct. So you can see that the space has increased. Can you see that? And since the increase in cranial cavity, so it is looking like a person is wearing a hat, so it is known as the Tam O'Shanter sign. These findings, again, it is important for MCQs, okay? Now coming to the Paget spine. Here what you can see? Picture frame vertebra, okay? See, the vertebra is looking like a picture frame. All the four sides have increased density. So it is known as picture frame vertebra. And this is known as the ivory vertebra, jekhane the whole vertebra has become hyperdense due to the disease, okay? So this is known as the ivory vertebra. So these two vertebral sign you can see in Paget's disease, picture frame vertebra and the ivory vertebra. Next, coming to the blade of grass or candle flame sign. So here you can see this is the bone you can see. So here you can see this part has become hypodense, okay? The cortex is thickened and this inner part has become hypodense. So this is, see, it is looking like tip of the V sign, okay? So it is known as a blade of grass or candle flame sign. Now you can see the loser zone over here. These are the fracture lines, see? এখানে pathological fractures হয়েছে, and you can see these areas, they are hypodense. They are small hypodense areas. So these are loser's zone. Loser zone, এর আগেও I have shown it in the other picture, okay? Now coming to the scintigraphy, if we do a technetium 99 scan, it will show increased uptake, okay? যেখানে diseased bones, they will show increased uptake in a technetium 99 scan. So here as you can see, the pelvis, they have taken increased uptake, the spine, the skull, sure, there is increased uptake of technetium 99. Now coming to the differential diagnosis, You can also suspect when a patient comes to you with these findings, you can suspect the patient is having osteomalacia, fibrous dysplasia, a multiple myeloma or osteopetrosis. So accordingly, you have to do the proper investigations. Okay. So coming to the treatment. So inactive lesions hole there, it does not require any intervention, but the goal of treatment should be suppression of the active disease, then relief of pain, prevention of the deformity and the fractures, then high output cardiac dysfunction should be corrected, and reducing the sarcomatous transformation, which is very rare in these cases. So coming to the suppressive agents, we should give bisphosphonates. Okay, bisphosphonates can be given, especially the second generation bisphosphonates. Few names you can remember, dosage I don't think so you all require at this stage. Then you can give vitamin D and calcium supplements to these patients. Then alkaline phosphatase you have to check. The alkaline phosphatase will help in seeing the progression of the disease. Okay. So in 6 months you will see that the alkaline phosphatase levels are also coming back to normal. So if that is happening, then you know that you are giving the correct treatment to the patient. And bisphosphonates should not be used in patients with renal impairment. Next, coming to calcitonin. Calcitonin and key function. What is the function of calcitonin? In the beginning I told you about 2 cells. The function of which cell is prevented by calcitonin? Osteoclast, correct. Okay, so we can give calcitonin to the patients. It will reduce the bone resorption by checking the osteoclastic activity. Okay. So next, if a person requires surgical treatment, then we have to correct the bone deformities. Then either we can do a total hip replacement or a spinal surgery. Okay. And pre and post operative calcitonin therapy, it gives a good results and reduces bleeding. Now see, this is a case, a patient had come. So ekhane we have done the alkaline phosphatase level, serum calcium and serum phosphorus levels. Calcium or phosphorus ki change hoyeche? Is it normal or abnormal? Normal. And what has happened to the serum alkaline phosphatase level? It is very much increased, right? Now tell me the normal levels. If 50 to 150 you can consider as normal. Okay, so now it varies from different lab to lab, but like less than 150 should be considered normal. Okay, so here you can see it has become 1510. The unit is very important, international unit per liters. Okay, so it is increased. So you can suspect, and the bone is also very much hyperdense, right? And you can see the prominent iliopectinate line. So you can suspect that this patient is suffering from Paget's disease. And same patient, the X-ray of the skull was also done, where you can see an increase in the diploid space and hyperdense skull. Okay.